Good afternoon. Welcome back. We'll begin the afternoon and final sessions today. So I'd like to begin with the polio session. Dr. Ornstein, would you please? Tom, I'm sorry. Go ahead.
Good afternoon. I'm Tom Shimabukuro with the Immunization Safety Office. And during this session, we will hear a historical perspective from Dr. Walt Ornstein on the U.S. transition from oral polio vaccine to the all-inactivated polio vaccine schedule. Dr. Ornstein is with Emory University and was the director of CDC's National Immunization Program during the switch. Dr. Ornstein will be followed by Mr. John Salamone. Mr. Salamone is a former consumer representative member of the ACIP. He is also a former member of the Advisory Commission on Childhood Vaccines. Mr. Salamone is accompanied today by his wife, Kathy. The Salamone son, David, contracted vaccine-associated paralytic polio from an oral polio vaccine he received as a child. The Salamone's public advocacy for switching to an all-IPV schedule was a key factor in accelerating the change. Lastly, we'll hear from Dr. Steve Kashi from CDC's Global Immunization Division. Dr. Kashi will provide an update on progress and prospects for global polio eradication.
Thank you very much, Tom. It's been 20 years since the U.S. embarked on an all-inactivated polio vaccine, or IPV, schedule in 2000. It was a difficult decision to abandon oral polio vaccine because of fears there could be polio outbreaks. But the fact that oral polio vaccine crippled people for life, and this was medical consensus, causally related, albeit very rarely, and crippled people when they had a perfectly safe alternative, inactivated polio vaccine, led to the decision to move to an all-IPV schedule. My goal today is to explain why the decision was difficult and what led us to make the decision to move to an all-inactivated polio vaccine schedule. And so I'll talk about three errors in time, and then take-home messages. We began polio vaccination with inactivated polio vaccine in 1955. In 1961, we switched to oral polio vaccine, and we kept that going until 1997, when we adopted a sequential schedule of inactivated polio vaccine, followed by live polio vaccine, and then the present era from 2000, and then again, what the take-home messages were. And this is a graph of polio in the United States. And the first thing I want to caution you is this is a log scale. So this is 10,000 and this is 10. So interpret this with caution. In 1961, we went to an all OPV schedule with 2 months, 4 months, 6 to 18, and 4 to 6 years. The sequential schedule included 2 doses of IPV at 2 and 4 months, and then 2 doses of OPV to get the benefits of both vaccines. And then we went to the 4 IPV. And what you could see here is a marked reduction in polio with the inactivated vaccine, but we still were seeing some problems with it at that time. Switching to the oral polio vaccine, a marked reduction. The last outbreak of polio in the United States was in 1979. No wild polio afterwards, but we still had about 8 to 10 cases a year of vaccine-associated paralytic polio, or VAP. And we switched to the sequential. It went down, but we didn't eliminate it. And then we went to all IPV, and we haven't had any polio since that time. And so the OPV era, Albert Sabin was the person who pioneered these live attenuated weakened viruses, and they were preferred for a variety of reasons. One, it was less expensive, substantially less expensive than the inactivated polio vaccine. Two, it was substantially easier to administer. You could train non-technical people to give it. It was oral as opposed to requiring injections. A big issue is it was far better at inducing intestinal immunity than IPV. Now, IPV and OPV both induced great individual systemic immunity. So they protected the central nervous system, but IPV on the intestinal side, and the extent that fecal oral spread was important or not, could be inferior. And another advantage of the OPV at the time, and this is before the detection of circulating vaccine-derived polioviruses, is passive spread of the vaccine viruses allowed us to immunize individuals who we weren't reaching in the immunization program, which would be completely susceptible switching to IPV. These are some data put together by Roland Sutter in two studies. One was by Yuri Gendon many years ago, and what he looked at is 4 groups of patients: susceptible control, IPV vaccinated, OPV vaccinated, naturally immune, then challenged them with a type 1 oral vaccine virus and look at the proportion shedding, the duration, the mean titer, and calculated an excretion index. And you can see here that IPV, with regard to fecal shedding, was not very different than the OPV group. They shed for a little bit shorter period, but substantially more than the OPV group, and then at a substantially 2 log, basically increase titer, although about a log difference from the completely susceptible individuals. And IPV was 95% better than nothing, but 5 times worse than OPV. What that meant, we really didn't know at that time. The other data are data from the late Ida Honorado and others, looking at kids who got a complete schedule of IPV or a complete schedule of OPV, and then were challenged with 2 doses of OPV. And what you can see here is, with regard to oral transmission, which would be dependent on pharyngeal setting, there was no real difference in IPV or OPV. They were equivalent. Where they were inferior, where IPV was clearly inferior, was in intestinal shedding. So one of the issues that was not clear is what was the major mode of transmission in the US at the time. The other advantage of the oral vaccine is the spread. This is a study that Bob Chen and others led, and what it looks at is in children in Detroit and Houston who are documented to be completely unvaccinated. And you see here, high proportions of them had antibody to polio, suggesting that passive spread of the oral vaccine virus was a good thing. We were reaching people we weren't reaching in the program. And remember, at this point, we knew nothing about circulating vaccine-derived polio outbreaks. And this just shows you where we came. This was looking in 1960 when we made the switch from IPV to OPV. We were still seeing between 2,500 and 3,000 cases, even though we had the IPV at that time, although it was not as potent as the current IPV. And then we switched and we came way down, but we had this constant level of polio going on. So one of the things that made us feel better, but in retrospect was not adequate, was there was a vaccine injury compensation program. So for the 8 to 10 people who were paralyzed a year due to the OPV, at least there was financial remuneration. And that started in October of 1988. And it applied not only to recipients, but also to passive contacts of recipients who developed that. And so I'd like to move then into the sequential schedule era, which began in 1997. And this is where, as I showed you earlier, the doses of an activated vaccine were given at 2 and 4 months, And we raised the age for the third dose at that time to 12 months. And that's in part because one of the major risk groups for paralytic polio from oral polio vaccine were those with immune deficiencies. And waiting to give the OPV gave more time to diagnose those immune deficiencies. And the hope here was to get the benefits of both vaccines. And this just shows you how we're talking about. Overall, we had about 1 case of vaccine-associated paralytic polio for about 2.4 million doses of trivalent oral polio vaccine distributed. The risk was highest after the first dose, 1 in 750,000 doses, less on subsequent doses. And these are some of the risk numbers. And what you could see here with first doses, this is the 1 in 750,000. And these are the categories. There were recipients, contacts, and then the community acquired, and then the immunologically abnormal, which were a big group, particularly those with B-cell immunity or defects. And what happened is, as this period occurred, we saw less and less of a risk of wild virus. So the concern was, why have continued use of this vaccine given the lower risk? In fact, in 1994, the Americas was certified as being wild poliovirus free, with the last case occurring in Peru in 1991. And at a meeting in June of 1996, we had parents and children with vaccine-associated paralytic polio come into the ACIP meeting, and it really had an impact on the thinking. I'll read you something from the ACIP minutes that were recorded at the time. And they said they described the parents' emotional and financial burdens, though significant, as inconsequential compared to their children's probably lifelong struggle to have a normal life. Repeatedly, they stressed that these strategies need not have happened. They agreed that OP's risk was not adequately conveyed. And here we're not talking about polio vaccine versus no vaccine. We're talking about a polio vaccine versus a polio vaccine, and one which was completely safe. It was very different than if all we had was OPV, we would have continued with OPV. So what were the reasons for adopting a sequential schedule? It was expected to reduce recipient VAC at least by 90%, maybe 100%. A sequential schedule could reduce contact VAP to the extent if IPV would reduce the shedding and transmission. The schedule also would, by delaying the OPV, would give rise to detecting immune deficiencies and potentially avoid them. We would get high levels of intestinal immunity with IPV. And one of the big issues was, if we went to IPV, there weren't combinations at the time, would the extra injections lead to deferral of polio vaccination, leading to accumulation of susceptibles or even other vaccines in favor of polio? And would we have some problems with that? And then stocking of both vaccines facilitates choice for providers. So this is what the ACIP said. The risk-benefit ratio had changed, that the exclusive use for routine immunization was not there given the rapid progress in global polio eradication. The relevant benefits of OPV to the U.S. population had diminished because wild polio virus was stopped in the Western Hemisphere, and the risk for vaccine-associated polio was now judged to be less acceptable because of that diminished risk. And this is just a summary of the advantages of an all OPV schedule, an all IPV schedule, and a sequential schedule. And what you could see here is these were the cases of VAP, serious adverse events. None of the others were known. All of them give very high levels of systemic immunity, so recipients were protected. These two gave high intestinal immunity. This gave the most secondary spread and required no injections, and this reduced that number of extra injections, and again, likely could be reduced with combination vaccines. And this was a substantially higher cost. And this was a study that I think is very important. It was done by Mark Miller, who was at CDC at the time, taking into account the higher costs of IPV. And the bottom line is, with a sequential schedule, the cost per VAP case averted was $3.1 million. $3.1 million. And the cost with an all IPV schedule was $3 million. Yet despite that, for moral and ethical reasons, we felt the need to switch. And so we move now into the IPV-only era. And I like to particularly call out Paul Offit, who played a major role having chaired the ACIP working group on polio during this period that really led us to this all IPV recommendation. And this just shows you what happened. And what happened is, with the change to a sequential schedule, we reduced VAP, but we didn't eliminate it. It wasn't that the IPV failed. It was the fact that providers having OPV in their stock, many of them were still giving OPV first without IPV. And so we were still seeing, with the sequential schedule, the problem. And this just shows you that a little bit more clearly if you look at figure 2 here. And you can see here that this was prior, while during the OPV only schedule, this was the IPV sequential schedule. And then when we went to the all IPV schedule, no cases of polio since 2000. So what are the key issues that led to that? Continued VAP cases were seen. There were no declines in childhood immunization coverage seen after adoption of the sequential schedule. There was no indigenous wild polio in the US since 1979, and the Global Eradication Initiative was further decreasing the risk of wild virus polio coming to the US. And this just shows you data, because this is one of the big concerns with coverage decrease. And the bottom line here is, with the injectable vaccine, we did not see a decrease in coverage. We did not see the fears of an increasing polio-susceptible population, or even susceptibility to other vaccines if people chose polio over other vaccines. And so in June of 1999, the ACIP recommended an all IP schedule, and these are the regions, that this schedule was adopted. So what are some of the take-home messages? Science is critical in making recommendations. There were things we didn't know, and it's hard. You have to make decisions without all the information you'd like to know, but you need to make those decisions. Epidemiologic and implementation science alone are not the only inputs into policy. Moral and ethical issues need to be considered. Cost effectiveness can be superseded. Had our concerns about the lack of intestinal immunity and decreased coverage with IPV turned out to be correct, we would have been severely criticized. But we had to make that decision based on what we knew, and this was the most appropriate decision. It's turned out to be the right decision. We've had no polio in the United States since 2000. Thank you.
We have time for one or two questions from the committee or comments, if Dr. Ornstein would be willing to take them. Dr. Hunter?
I think this is a great example of what history can teach us, and I think it's not necessarily, it may be the best example, but it may not be the only example in the history of ACIP that shows how we need to balance difficult issues, safety issues, and other issues where we need to make a decision but don't have the information. So I hope that you, because I'm on my way out, get an opportunity to do this kind of thing again. I think it would be very helpful.
Dr. Kimberlin.
David Kimberlin, AAP Red Book. My recollection is there was perhaps an enhanced IPV product. When was that developed, and how did that factor in with the decision making?
That was licensed in the 1980s. I forget exactly the year, but that did play some role because, in essence, the IPV used in the 50s was not as potent and not as immunogenic as that IPV. So it did play a role, David.
So that was the only IPV product available then by the time these decisions were under consideration?
Correct. We had the enhanced potency at the time these decisions were undertaken.
And did the sequential approach as an option, was that on the table from the beginning? I think I might have just thought it's one or the other if I had been at the table back then. Who thought of the sequential approach?
I think the debate was one or the other initially. And the sequential was thinking about getting the benefits of both vaccines. And there were data from Hungary, for example, where IPV preceding OPV caused a major reduction in VAP. So the sequential sort of was a no-lose until we found out you did lose, but was thought to be the best schedule to begin with. And clearly it prevented we had no cases of VAP between 97 and 2000 in people who received the sequential schedule. All of them were OPV to start, but we would gain the benefits of both vaccines, and that's what did it. But it wasn't the initial proposal.
So thank you again, Dr. Ornstein. I think that these presentations allow us to look back at the efforts that the ACIP has made and allows us to focus these past efforts on current problems and projects. So thank you again very much. Mr. Salamone, please.
My name is John Salamone. I want to thank you for having me appear today before ACIP. It's been 17 years since I served on this committee, and it's nice to be back among familiar faces, and I might say friendly faces. As most of you know, I found myself thrust into the polio vaccine debate because my son David, who was born with Bruton's disease syndrome, immunodeficiency disorder that prevented him from making B cells. Because of that genetic disorder, David, like dozens of other U.S. children at the time, contracted polio from the oral vaccine as an infant in 1990. It left him with an atrophied leg, but with the help of physical therapy, a brace, and a supporting family, he lived a somewhat normal life. After dealing with the initial grief of seeing our only son disabled, my wife, Kathy, and I determined to find out why. Why would a seemingly healthy baby overnight suddenly lose the use of his leg? What we discovered was that other children experienced similar adverse reactions each year from OPV, even though there was a safer and just as effective IPV. However, removing an entrenched vaccine from the market that has been a mainstay in our immunization history for 40 years was not easy, but it had to be done. OPV did its job, and it did it well. But any vaccine needs to undergo a periodic benefit-risk evaluation. In the case of OPV, the only case Cases of polio in the U.S. for decades stemmed from the very vaccine meant to eliminate the disease. Changing to a safer IPV schedule was critical and overdue. With my background in journalism, I knew I could write, so that's what I did. I reached out to magazines, newspapers, broadcast media to tell David's story and the need for a safer all IPV immunization schedule to replace the current all OPV schedule. To my surprise, I started to get calls, and stories on David began to appear in newspapers like the Washington Post and the New York Times, as well as magazines including Good Housekeeping and Family Circle. Since I worked in the Congress in the 1970s, I contacted some old friends and even the White House, since Clinton Chief of Staff Leon Panetta was a friend for 20 years. We felt we were getting out the word, but nothing was changing. We desperately wanted a safer polio vaccine, but we knew we could not get it with just press and politicians. We made our case to the media and to the Congress, and now we needed to focus on the decision makers and work within the system at the CDC. It was time to go to Atlanta. I researched and discovered dozens of other VAP families throughout the United States. We shared our stories and our pain. I convinced many of them to join us at a meeting of the ACIP in June 1996, in a room much smaller than this, in another building. It was clearly a turning point. I think we spoke to the hearts and minds of ACIP members. For the first time, they saw the faces and braces of those behind the statistics. It helped those kids, and especially my David, feel they could make a difference and help others. Their sacrifice was not in vain. While it took several more years, ACIP transitioned to an all IPV schedule in 2000, and since that date, there have been no cases of vaccine-associated pelvic polio in the United States. We can now truly say since the year 2000, polio has been eradicated in the United States. I learned several things from this experience. I learned the professionals who work at the CDC and who serve on important committees like ACIP are dedicated, intelligent, caring individuals who take seriously their responsibility to create a world where people are not injured and die from preventable diseases. Because of your work, many of those diseases, such as smallpox, measles, rubella, tetanus, diphtheria, and of course polio, have been virtually eradicated in the U.S. And today, the CDC and ACIP are on the front lines of protecting Americans from the growing concern of coronavirus. You have saved too many lives to count, and I'm grateful to you for the decisions you've made based on science and not rumors and unwarranted fears. I wish David were here today on the 20th year since VAP Free America. As you may know, he passed away on September 7, 2018. On his last ambulance ride to Georgetown Hospital, he said to his mom, I wanted to do something good. I wanted to do something good for people. I know I could help. I hope you agree. David did good, and he helped. We are grateful. We are grateful you recognize his contributions and those of others for a safer U.S. immunization program. Thank you.
If Dr. Ornstein and Kathy Salamone could please join me on the stage. Through the generosity of the CDC Foundation, we have a plaque honoring David Salamone, his parents, John and Kathy, and other families who advocated for switching from OPV to IPV. Immediately following the session, the plaque will be on display in front of the CDC library. Walt and John, if you could do the honors. And Kathy. Oh, I'm sorry. So, the plaque reads, "In honor and recognition of David Salamone, who successfully advocated for the U.S. immunization program to discontinue use of oral polio vaccine in favor of inactivated polio vaccine. David contracted polio from the oral vaccine he received as a child. He and his parents, along with other families affected, helped show the human consequences of vaccine-associated paralytic polio, VAP. Since 2000, when the United States adopted an all-inactivated polio vaccine schedule, not a single person in the United States has contracted VAP." Thank you, John and Kathy, and thanks to all the families that advocated.
So let me say, I think for those in the audience that don't know this, I think everybody around the dinner table knows this, that Mr. Salamone was the first consumer representative on the ACIP, and his work continues today through each subsequent generation of consumer representative we have. So you have a living legacy on our committee, sir. Thank you. Dr. Kashi.
Okay, now to conclude this polio session, I would like to give you a very quick update on where we are with polio. In our effort to get rid of all poliovirus disease, both wild-type polio and vaccine-related polio. First, I'm going to give you the good news, then I'm going to give you some bad news. This slide shows you the four main strategies that we are following in the polio eradication effort. I'm going to focus on strategy 1, poliovirus detection and interruption. First, some of the good news. You see here the effort which began with the World Health Assembly resolving unanimously to eradicate polio. Started with about 350,000 cases of polio in the world, and there was a rapid decline in the incidence of polio. And currently, as of the end of 2019, there are only 3 endemic polio countries. Noted in red. We have Pakistan and Afghanistan and Nigeria. And Nigeria, although it's still considered an endemic country, has not had wild virus polio in more than 3 years. So it soon may come off the list of endemic countries. Major milestones: the last type 2 wild poliovirus occurred in India in 1999. And India had the last wild poliovirus case in 2011, a major milestone in the world. In 2015, the Global Certification Commission formally certified the world as free of wild type 2 polio, and the same thing occurred for the type 3 virus in 2019. We have not seen a type 3 wild virus anywhere in the world since 2012 in Nigeria. Now, some more good news. Given the global effort, the accelerated global effort, since 1988, the number of polio cases averted on an annual basis globally has increased tremendously, so that cumulatively we have prevented through polio vaccination nearly 19 million polio cases in the world. And this shows the certificate that certifies the world is free of wild poliovirus 3, signed on October 17, 2019, by the Global Certification Commission, headed by Professor David Salisbury of Great Britain. So the good news, just to summarize, more than 7 years have passed without detection of wild poliovirus type 3. The Global Certification Commission certified wild poliovirus 3 eradication last fall. The number of inaccessible children in formerly Boko Haram-controlled areas in Borno State, Nigeria, that's the northeastern state of Nigeria, has been drastically reduced from about 500,000 children that are inaccessible in 2016 to a current estimate of about 30,000 children that are still inaccessible. A lot of this is determined, these estimates are determined by satellite photography that's done on a regular basis to look at the villages and towns that are still in existence or have been destroyed or burned by Boko Haram. More than 3 years have passed without detection, there's a typo there, of any wild poliovirus in Africa, and the African Regional Certification Commission will convene in June 2020 in Nigeria on a preliminary basis to determine regional certification of all wild poliovirus disappearance in the African region. IPV supplies are now sufficient for routine immunization, and catch-up of missed cohorts is in progress. There was a big problem with supply when we added IPV to OPV-only using countries, and we have a cohort of about 40 million children that need to be caught up since 2016. The European region, the Pan American Health Organization, the Southeast Asia region of WHO all remain polio-free, including from circulating vaccine-derived polioviruses, and I'm going to talk more about those in a few minutes. And Gavi, the Vaccine Alliance, has joined the GPI, the Global Polio Eradication Initiative. Okay, now some of the bad news, and we'll take this in two stages. First, as it relates to wild poliovirus, which is shown in red on this map graph, and this is a graph of the polio cases in the previous 6 months in the world. You see that wild poliovirus type 1 is limited to Afghanistan and Pakistan, with the bulk of cases occurring in Pakistan. We also have these green dots, which are cases of circulating vaccine-derived poliovirus type 2, and a small number of yellow dots. You see here in Malaysia, this is an outbreak of circulating vaccine-derived poliovirus type 1 in Malaysia and the Philippines. So the bad news, well, wild poliovirus type 1 cases increased from 33 cases in 2018 to 173 cases in 2019, 144 of those in Pakistan, where there was a big surge in polio cases. In Afghanistan, the Taliban ban on house-to-house vaccination is severely affecting the ability of the program to carry out campaigns. In Pakistan, a new government is starting to provide national leadership, but more than 6 months passed in the second half of 2019 without large-scale vaccination campaigns, and wild polio cases surge. AFRO, the Eastern Mediterranean region, and the Western Pacific region of WHO all battle outbreaks of type 2 circulating vaccine-derived poliovirus. So just a little bit of explanation about what these circulating vaccine-derived polioviruses are. Well, you know that the polioviruses can rarely regain the ability to cause paralysis. Trivalent OPV has attenuated wild polioviruses, and that attenuation results in markedly less ability to cause paralysis than wild poliovirus, less capacity to pass from person to person, and while a similar induction of antibodies as wild poliovirus. Now, oral polio vaccine viruses in areas with low polio vaccine coverage can rarely mutate during prolonged circulation. And that mutation consists of back mutations to make the virus neurovirulent, as well as recombination events with non-polio enteroviruses to make the vaccine viruses more able to transmit, more akin to wild polioviruses in their ability to transmit in populations, in communities. So these viruses become vaccine-derived polioviruses. That's the scientific name given to these viruses. They're able to spread and cause paralysis and cause outbreaks rather than just isolated cases of vaccine-associated paralytic polio. Those viruses are only result of back mutations toward neurovirulence. So, when we look at how to prevent these vaccine-derived polioviruses cases from occurring, and we had 700 paralytic cases due to the type 2 circulating vaccine-derived poliovirus confirmed during the 15-year period 2001 to 2015, while there were no wild type 2 polio cases occurring in the world. I told you that the last case was in 1999 in India. This prompted the strategic decision to withdraw OPV2 use in all routine and supplementary activities, going from a trivalent vaccine to a bivalent 1 and 3 serotype vaccine. So, in 2016, the policy was implemented to remove the type 2 component and go to a bivalent vaccine in 155 OPV-using countries in the world. This was a switch that took place over the course of about 1 month. A massive effort because it involved taking back from communities, from health facilities, all the way down to the health facility level, every vial of trivalent OPV and destroying all of those vials and not distributing any more trivalent OPV. We also have worked very hard to add IPV so we can benefit from both vaccines, OPV and IPV. The IPV complements trivalent OPV by increasing immunity to all 3 types of polioviruses. And this is part of a transition that we hope to achieve to withdraw all OPV from the world. The IPV will provide protection against paralysis from type 2 polioviruses, as well as boost immunity against type 1 and type 3. And in previous OPV recipients, as well as OPV recipients, not only the type 2 component, but the types 1 and 3 will have their intestinal immunity to infections boosted by the addition of IPV, those recipients of OPV, of trivalent OPV. We also have had strategic use of IPV in response to type 2 poliovirus outbreaks alongside monovalent OPV type 2 mass campaigns to increase population protection from paralysis. So what was the result? You see here a bar graph that graphs all of the CVDPVs detected since the year 2000. This was the first well-described vaccine-derived poliovirus outbreak on the island of Hispaniola, and it was actually a type 1 circulating vaccine-derived poliovirus outbreak. We had a predominance, as I described a few minutes ago, during this period of time of type 2 circulating vaccine-derived polioviruses, peaking in 2009, and the majority of these were occurring in Nigeria. And then the switch happened in 2016. You see that we reached a nadir of circulating vaccine-derived polioviruses at that point in time. Then some bad news ensued. After reaching that nadir in 2016, both in the number of type 2 CVDPV cases and the number of countries that were infected with such viruses, which is this red dotted line graph, a resurgence occurred in the ensuing 3 years. And in 2019, we had an enormous increase in the number of type 2 CVDPV cases in the world, as well as the dramatic increase in the number of outbreaks, as shown in this bar graph to the right. So this is an unprecedented phenomenon that we have been dealing with. So several outbreaks have been terminated. Quite a few outbreaks have actually been terminated through the use of the monovalent OPV Type 2, using it in a mass campaign and successfully implementing 2 or more rounds of this use of this monovalent vaccine. But if these mass campaigns are not done with high quality, then there is a persistence, we're left with a persistence in many of these developing countries, many of which have very low routine immunization coverage. And 4 or more rounds can be required. We have not even been able to stop in some of these countries these outbreaks with more than 4 rounds. And many new emergences are occurring across the African region, which is characterized by many countries with weak immunization systems, low routine immunization coverage, therefore low population immunity against the type 2 virus. And increasingly, outbreaks are beginning to occur in areas where we haven't used the monovalent type 2 OPV in a mass campaign. These outbreaks tend to occur in these low-performing countries around the edges, just outside of the targeted geographic area for the OPV2 mass campaigns. And these outbreaks are being caused by decreasing population immunity, mucosal immunity, and as well as systemic immunity as a result of withdrawing OPV2, and through population movement from the areas, the geographic areas where monovalent OPV2 is being used, to areas adjacent to that where it wasn't used. So we have an evolving new challenge that we've never faced before. The program's battling many outbreaks of CVDPV2 in sub-Saharan Africa, and the program is at risk of reestablishing poliovirus type 2 endemicity in Africa with the circulating vaccine-derived virus. There's now detection of outbreaks in Asia, in China, Pakistan, Philippines. This may herald a global emerging problem. And we have a limited supply of global monovalent OPV2 in our stockpile, which requires balancing its use with the availability of new shipments and the need for more production. So I just wanted to show this article by Helen Branswell, who is a well-known journalist, science writer. For many years, she has followed the polio eradication situation. Last fall, she published an article entitled "The Switch Was Supposed to Be a Major Step Toward Eradicating Polio. Now It's a Quandary." And I put over on the right what a quandary is, because I would have to look it up myself to And this is what the dictionary definition is: a state of perplexity or uncertainty over what to do in a difficult situation. So where do we go from here? Well, we are trying to improve on the suboptimal quality of the monovalent OPV2 campaigns by more rapid deployment of the supplies of the vaccine, revised strategy guidance for controlling and terminating these outbreaks, which was finalized last month and presents a more aggressive strategy, and increasing the scope and quality of these SIAs, these mass campaigns, with a surge in technical support. We're also working to accelerate the development and regulatory review and use of novel OPV Type 2 through the emergency use listing. So I've introduced two new concepts. What's novel OPV2 and what's emergency use listing? So let me go through and tell you briefly what this is about. Well, novel OPV Type 2 is a genetic modification of the existing OPV Type 2. The modifications made are designed to improve the genetic stability of OPV. There are two candidate vaccines, and incidentally, for the past several years, the Gates Foundation has invested heavily in the development of this new vaccine, as well as novel OPV1 and novel OPV3, which are not as far along in the development stage. But the two candidate vaccines have multiple changes in the genome, both on the 5' end and on the 3' end, and one of the vaccines also has multiple changes in the nucleotide sequence in the P1 region, which is the capsular protein. So these redesigned vaccines, we believe, will decrease the risk of seeding new CVDPVs and the risk of vaccine-associated polio when deployed under outbreak control circumstances. Now, what is the EUL, or the emergency use listing? And we are accelerating the regulatory approval process for this new vaccine under EUL. Well, the owner of EUL is the WHO Essential Medicine Department, and the goal is to make, under emergency circumstances, experimental health products available for emergency response. It's very new, and there as yet are no products that are listed under the EUL so far. And the eligibility criteria for such a new product is that it has to be a product that deals with controlling the spread of a disease that has already been deemed a public health emergency of international concern, which is under the international health regulations governed by the World Health Organization. We know, some of you know, that coronavirus has been declared recently a public health emergency of international concern. There are very few such instances where this has been used. But this is the fastest way to obtain regulatory review and approval. I'm getting near the end of my presentation, but I just wanted to describe very briefly for you what is the process that we're going to have to go through in the clinical development and production of the novel OPV2 to align with this EUL approval. Well, there already have been many studies conducted in adults and more recently in children to develop the database on immunogenicity and safety, shedding of these viruses in 1 to 5 year old children. Genetic stability has occurred in adults and is a process of being studied in young children, and also a pilot production scale facility which is in Indonesia. The WHO review process, they have told us that this process will take the next 3 months, and during that period of time, some pilot doses of vaccine, about 4 to 8 million doses are being developed by the Indonesia manufacturer. There will then be further studies on the genetic stability that will data that will come out, updated stability data, and more examination of the production facility on a commercial scale through a 1-month review. But by mid-year, July, August of this year, we hope to have 100 million doses commercially available for use in the field, and by the end of the year, another 100 million doses. So that's 200 million doses of this vaccine, which we intend to use in a transition period as a replacement for the current monovalent OPV2. So in summary, polio eradication has made some progress in 2019, but encountered serious challenges, which I think I have brought home to you as some of the very difficult challenges that we face right now. Wild poliovirus eradication requires access in Afghanistan and vaccination quality improvements and accountability in Pakistan. The circulating vaccine-derived type 2 outbreaks threaten the success of the switch that was conducted in 2016 and may lead to reestablishment of type 2 endemicity. Monovalent OPV2 needs to be replaced as soon as feasible by genetically more stable novel OPV2. A second dose of IPV in the routine immunization program of all countries is under discussion when supplies allow, and we think that supplies are going to grow with entering into the market of a number of developing country manufacturers, so that this could take place in the near future. And finally, securing the funds to run the program is a very high priority and has been stressed by having to respond to all of these vaccine-derived poliovirus outbreaks. So I'll end there, and if any time is available, I'll try to respond to questions. Thank you.
Are there any questions from the committee? Dr. Smith, please, the microphone.
Thank you. I think this is a question for you, Steve. I'm Jean Smith, retired from CDC 2018, and had the good fortune to be seconded from CDC to WHO in India, Nepal, and the Southeast Asia region from 1995 to 2005, thanks to Steve Kashi. My question is, can you say something about the situation of VAP in countries still using OPV, if the incidence is known, and the awareness and reaction if there is VAP in these countries?
Thank you, Jean. In the OPV using countries, there continues to be VAP, although it's very difficult to define what is a VAP case and what isn't in these developing country situations, because we don't have the technology available that we do in industrialized countries like the U.S. to make those distinctions. But we know that we can say in a general sense that the incidence of VAP has decreased substantially since the type 2 OPV was causing about 90% of all of the VDPV cases, and is responsible or was responsible for about 40% overall of all of the vaccine-associated polio cases. So we can say in a general sense that the incidence of VAP is down. We want the incidence of VAP to go to zero by withdrawing all OPV, including the use of bivalent OPV. But these problems that we have with the CVDPV outbreaks have delayed our transition toward an all IPV future.
Are there any other questions from the committee? From anyone else? All right. Thank you very much. for your presentation, Kashi. Everyone, we will take 2 minutes, please, if you'd like to stretch your legs. Okay. Next topic is hepatitis B. Work group update by Dr. Sharon Fry.
Hello, I will try to make this very brief presentation even briefer in the interest of time. So the hepatitis B working group is still continuing their work, and our current term of reference at this time is to update the recommendations for the hepatitis B vaccination among U.S. adults. So the current recommendations for hepatitis B have been updated twice since 2008, and this included new recommendations plus several updates, and also included the recommendation for use for adjuvanted hepatitis B vaccine. The work group has been busy since September through November. We have developed a PICO question and have estimated denominators of risk groups. In January, we gave a presentation of interim results of post-marketing surveillance study that was done by the principal investigator at Kaiser, and prepared our discussion for spring of 2020, which will include discussion of cost effectiveness analysis, and which is under review at this time in an external work group. Our policy question under discussion for this next round is, should a routine universal hepatitis B vaccination strategy, whether it's 2-dose or 3-dose schedule, be utilized versus the current risk-based vaccination strategy for high risk only for 2-dose and 3 doses for adults? And that is just laid out here for you. Universal vaccination strategy versus current risk-based vaccination strategy. Next steps will continue deliberations on updates to adult hepatitis B vaccination, and that will be to complete the CEA review process and present the CEA to the work group, discuss the final results of the post-marketing surveillance study for Hepaslav when available, and initiate the grade and evaluation to recommendation framework for universal adult hepatitis B vaccination. I'd like to thank our work group, which includes me and Jose Romero and our lead, Mark Wang, and thank the ex officio members, liaisons, and consultants. Also acknowledgement to a variety of organizations and people, including the CDC subject matter experts. Thank you.
Thank you. Any questions? Okay. Thank you, Dr. Fry. Our next speaker is Dr. Hunter, who will be talking about general best practices introduction, followed by Dr. Kroger.
I'm the outgoing chair of the General Best Practices Work Group. The terms of reference for our work group are to revise the ACIP General Best Practices Guidelines for Immunization. The last revision was in 2019, sections of which are to be revised every 2 years. Address the issues related to general best practices for vaccines and immunization programs, and work on emergent issues that do not clearly belong to specific pre-existing work groups. The adult and child adolescent schedules summarize the ACIP vaccine-specific recommendations for implementing those recommendations in clinical and public health practice. There we go. The general best practice guidelines help clinicians, nurses, pharmacists, and other vaccinators answer practical questions that are not or cannot be directly addressed by vaccine-specific recommendations. There we go. And this is a slide you'll see again in Dr. Kroger's presentation. He's going to be doing a presentation that will be for information and, if needed, discussion, although we don't expect too much discussion. The general best practice guidelines are CDC guidance with input from the work group. Major changes require discussion by the ACIP, but rarely would require a vote. Updates are uploaded to the ACIP website on a rolling schedule, and that's mainly in order to maintain accreditation for continuing education credit. And Lynn Bata is the incoming chair for the group, and Pablo Sanchez is the other ACIP member. I want to thank the liaisons, ex officio, CDC staff, and scientific consultants. And now our fearless leader, Dr. Andrew Kroger.
Thank you, Dr. Hunter. So I'm going to use the next couple minutes for an informational session, which will kind of complete a loop that began at the October 2018 meeting involving content that was added to the general best practice guidelines following a discussion at ACIP. And then I am going to provide additional updates that have been posted in the past year. This is informational only. So I will continue the background. However, this is the landing URL, the landing page for the HTML version of the general best practices document that Dr. Hunter showed. Each of these light gray banners you see in the middle of the slide really reflects a separate listing of all of the general topics for general best practices. Which include, in addition to an introduction to changes that have occurred, the methodology, and then the meat of the subject, timing and spacing of immunobiologics, contraindications and precautions, preventing and managing adverse reactions, reporting adverse events after vaccination, vaccine administration, storage and handling of immunobiologics, altered immunocompetence, special situations, vaccination records, vaccination programs, and vaccine information sources. And this does kind of break down into, if you look at timing and spacing of immunobiologics through storage and handling, that covers the immunization encounter. And then, of course, we have some special topics, altered immunocompetence, special situations, and then there are some programmatic sections as well to the document. When you go back to the landing page for the general best practices, note that over on the right side is the link for information on how to obtain continuing education credit. The most recent renewal of the credit was in April of 2019. That followed the October 2018 discussion, which I will talk about in a little bit more detail. Note that the general best practices document exists in a PDF format as well, which you can obtain by clicking here. And so this was the new cover page after the discussion, the new authorship for the document, which included myself and all of the ACIP chairs since the previous iteration of the document in 2017. And I will also mention that you can access a PDF of the entire document, or you can obtain an individual PDF of the separate chapters as well. And this is important because revisions are occurring constantly to this online document, but the pagination stays the same. but it's very unlikely that a PDF of the entire document will remain timely for very long. So you can print out the new section, but you may not have to print out the whole section. So how do you know what the changes are? There is a list of errata and updates that are made to the document, which is right here above the continuing education block. When you click on that, it looks like this. Every revision is indexed by the date in which the information was uploaded in the order of the most recent changes, with links to the appropriate areas of the document. May 14th, 2019 was the cycle change of the new CE package. So that's when we added content on vaccine administration. The vaccine administration section was revised to reflect the ACIP presentation that occurred on April 25th of 2018. So it was a change to this section. And what was the change? If you'll recall, back to 2018, it was a section called Healthcare Provider Exposure to Vaccine Components. And so this was the new language. Providers are sometimes concerned when they have the same contraindications or precautions as their patients from whom they're going to withhold or defer vaccine. For administration of routinely recommended vaccines, there is no evidence of risk of exposure of vaccine components to the healthcare provider. So conditions in the provider labeled as contraindications and precautions to a vaccine component are not a reason to withdraw from this function of administering the vaccine to someone else. Historic concerns about exposure to vaccine components are limited to non-parenteral vaccines in which some degree of environmental exposure is unavoidable, or situations in which self-inoculation is likely due to the nature of the vaccine microbe, by way of example, reduced attenuation of the smallpox vaccine virus. And then I added a caveat: persons administering ACAM 2000 smallpox vaccine to laboratory and healthcare personnel at risk for occupational exposure to orthopox viruses can decrease the risk for inadvertent infection through recommended infection prevention measures. However, because of a theoretical risk for infection, vaccination with ACAM 2000 can be offered to healthcare personnel administering this vaccine, provided individual persons have no specified contraindications to vaccination. So that is the language that was posted to the document based on that discussion. So I felt it was very important to kind of cycle back and let the ACIP know that this was done. The content shortly after it was posted has been promoted as well. So those implementation activities did continue. Now, I want to also cover updates that have been made in the past year. And I just have one more slide left to go through the recent updates. And so they're in three sections. First, in timing and spacing. And all of this, by the way, is content that is already in an MMWR vaccine-specific statement. So, of course, none of this is new. These are updates. The first is the addition of the 2-dose series of HPV vaccine, which was added to the timing and spacing interval table. So it accompanies the 3-dose series, which remains on the table. There also was a timing and spacing addition. HIV was added to conditions for which PCV13 and Menactra brand MenACWY should be spaced by 4 weeks. As you recall, there's a functional and anatomic asplenia, but HIV is another condition. Providers are recommended to administer PCV13 first and then MenACWY Menactra 4 weeks later. There are three additions to the contraindications and precautions section. One, we carved out an exception for recombinant zoster vaccine. There is no need for, there's a typo there, for an interval between recombinant zoster vaccine and anti-herpes antivirals. This is a non-live vaccine, so that concern about interference does not exist with recombinant zoster vaccine. We had to make some changes to some of the listings in the table because of components that were identified. Yeast is acknowledged as a component of PCV13, so it's necessary to put this on the table. It's relevant when discussing allergy. And then the last contraindications and precautions change is the addition of language to the HPV vaccine column. The language that states that HPV vaccine is not recommended during pregnancy. This follows the removal of HPV vaccine as a column listing for precaution, because pregnancy is not a precaution to HPV vaccine. It's that HPV vaccine is not recommended in pregnancy. And then the last change for storage and handling, there was content that had been removed from the previous published MMWR version of the general best practices. We had to add this information back in. Information about how to repeat doses of vaccine that are administered and then later found to be expired. And so we put this language back in. There is some interesting nuances here. Of course, as you know, inactivated, or let's call them non-live vaccines, generally would not require an interval from the vaccine that's invalidated because it's expired. You would just repeat the dose ASAP. There is an exception to that, and that exception is Shingrix, which is not live, but we do require a 4-week interval because of safety considerations. So those are the most recent additions in the past year that have been made to the general best practices, and I'm happy to take any questions that folks may have.
Do any of the committee members have any questions? Thank you, Dr. Kruger. Anyone else? Questions or comments? Okay, thank you very much.
Thank you.
Right. Final presentation will be vaccine supply update by Dr. Santoli.
Hi there. I'm going to have a very brief update for you this afternoon on vaccine supply. I'm going to focus my update on pediatric and adult hepatitis B vaccine, and then just remind you about our vaccine supply and shortages webpage. A lot of times I'm up here sharing not so good news, so this is a very positive update. I'm excited to be able to share with you that in terms of the pediatric hepatitis B vaccine, Merck plans to begin distributing its pediatric monovalent hepatitis B vaccine in the private sector effective March 9th, 2020. You may recall from some of prior updates that Merck's limited supply had previously been targeted toward the public sector using CDC's vaccine contracts. And now it will be available in the private sector as well. In addition, they project that available supply of monovalent vaccine will be sufficient to meet historical demand for this vaccine in both the public and private sectors. In terms of adult hepatitis B vaccine, Merck is not currently distributing that vaccine or the dialysis formulation, and will not be doing so through at least the first half of 2020. So I'll share additional information as we have it. Regarding adult vaccine, however, Dynavax and GSK, who both make alternative products, have sufficient supply of adult hepatitis B vaccines to address the anticipated gap during this period. However, preferences for specific presentations may not always be possible. And then lastly, I wanted to just make sure that you know we maintain a web page where we keep the latest and greatest information about vaccine supply. So you might want to bookmark this link, and we'll be updating it to reflect this information next week. Thank you.
Open for questions. Dr. Hunter.
The adult hepatitis B vaccine shortage is not new, right? That's an ongoing shortage?
It's been ongoing for a couple of years,
Okay,
yes.
just wanted to make sure.
Yeah. But the new information is that when I talked about this back in October, I indicated the information was that there wouldn't be distribution through the end of 2020, and now I'm saying through the first half of 2020. So that foreshadows, and we're hoping that we will have another update the next time that we talk.
Any other questions from the committee or liaisons ex officios? None being, thank you very much, Dr. Santoli. That brings us to a close of this February meeting. Our next meeting will be in June 24th, 25th. We look forward to seeing you then. Book your tickets. Have a safe trip.